Just a nurse. That's what Dr. Pierce called her when he thought she couldn't hear, voice dripping like honey across the doctor's lounge as he stirred his fourth espresso of the night. Just a nurse who didn't know her place. They didn't know. None of them knew. Sarah Chen moved through St. Michael's ICU on the night shift like someone reading a language everyone else had forgotten. Colorado Springs, 11:22 p.m., fluorescent lights buzzing their electric hum overhead, antiseptic sharp enough to strip paint from the air. The monitors beeped in staggered rhythm, a mechanical heartbeat that never missed a stroke. She checked the ventilator on bed for without consulting the chart, hands moving with the fluid economy of someone who'd done this 1,000 times. Not in hospitals. Somewhere else. Somewhere darker. The fall line was running at 27 milliliters per hour. Should have been 30. She adjusted the pump with 2 fingers, the soft click barely audible beneath the ambient hospital noise. 12-gauge angiocath, clean stick, no infiltration. She'd placed it in one attempt during handoff while the day nurse was still talking. The day nurse hadn't even noticed. A scar ran from her left wrist to her elbow, pale against brown skin, map of something that had happened a long time ago in a place she wasn't supposed to talk about. She wore long sleeves in summer. Winter too. The scar was muscle memory made visible, what happens when shrapnel teaches you to move faster than pain travels. When she hung her jacket in her locker at 11 p.m., her fingers brushed the inside lining where a unit patch had been sewn in faded black thread. Delta Force. 18th Special Forces Group insignia. A gift from a medic she'd saved in Baghdad when he was bleeding out and his own unit had already written him off. She touched it the way some people touch rosaries. Daily ritual. Nobody saw. The thing about night shift at St. Michael's was that it moved in 2 speeds. There was the official speed, the one where nurses bustled and doctors arrived for rounds and everything happened by protocol. Then there was the real speed. The one where Sarah moved. Her fingers found the chest tube connection on bed 6 without looking. The tubing was kinked. 18-inch coil of plastic and silicone that would back up pressure in a pneumothorax, kill the patient in 4 hours if nobody caught it. She straightened it, checked the water seal chamber, 2 centimeters of fluid, perfect, and was 3 steps away before the night resident even looked up from his phone. She'd been a resident once. Different uniform. Different rules. Dr. Pierce arrived at 11:52 p.m. for night rounds, his white coat so pristine it looked like he'd put it on in the last 60 seconds. Maybe he had. His resident trailed behind, a kid named Jacobson who wore his anxiety like cologne. The attending physician walked like someone who'd never made a mistake in his life and saw no reason to start now. That was the dangerous kind. The kind who never questioned himself. Sarah was finishing a sterile dressing change on the trauma patient in bed 2. Colonel Reeves, 84 kilograms, admitted 6 hours ago with a sheared intercostal artery that the day shift had barely managed to stabilize. She'd already changed the dressing once. She was changing it again because the edges were starting to show signs of drainage seepage and infection rate spike at exactly 72 hours post-admission. Nobody had told her to do it. She just knew. Her hands moved over the surgical site with a precision that made the whole thing look like choreography. Sterile gloves snapped onto her wrists like applause. Betadine swab in 3 smooth passes. Fresh gauze with antibiotic ointment. Tape sealed at 90-degree angles. 40 seconds. She didn't count anymore. Her body kept time. That's when Dr. Pierce saw her. The way she secured the final corner of the dressing. The way her fingers didn't hesitate. The way she checked the subcutaneous drain without the chart telling her what to look for. 14 milliliters in the bulb. Normal. But she was looking for something specific, some sign that told her whether it would be 13 tomorrow or 18. She was reading the patient like a text written in a language only certain people understood. Pierce's eyes narrowed. A muscle tightened along his jaw. Morning rounds, he said to Jacobson, loud enough to carry, and the resident hurried ahead to bed 1, where the sedated patient didn't need anyone's opinion. But Pierce hung back. Watched. Sarah felt the weight of his attention the way soldiers feel incoming mortar rounds, pressure on the air, an electromagnetic charge that told her everything she needed to know. A predator had spotted something that didn't fit the hierarchy. She finished dressing the tube connection and turned to move past him toward the med cart. Didn't make eye contact. The protocol for peace in hospitals was the same as the protocol for survival in combat zones: make yourself smaller than the power. Invisible. Apologetic for existing. Ms. Chen, Pierce said, and the way he said her name made it sound like he was reading it off a list of things that disappointed him. Come here. She came. Jacobson was already at bed pulling vitals on the post-operative patient, a woman named Martinez with enough complications to keep them all busy until sunrise. But Pierce wasn't interested in Martinez. He was interested in the thing that had moved too confidently through his ICU. The 4-line you placed on Colonel Reeves during handoff, he said. Not a question. Walk me through your insertion angle. Sarah's voice when she answered came out flat and level, the kind of flat that meant she'd already catalogued 3 escape routes and registered that his stethoscope was hanging wrong and his resident's pulse was elevated. 18-degree angle to the skin surface. Bevel up through the antecubital fossa. 1 attempt. No complications. 18 degrees. Pierce smiled. The smile had teeth. That's unusually precise for someone just starting and 4-line. It's the angle that minimizes valve damage on the way in, she said. Still level. Still professional. Still a nurse explaining basic anatomy to an attending who'd forgotten everything he learned in med school. Reduces hemolysis by approximately 14% compared to the standard 25-degree approach. Hemolysis. He repeated the word like he was tasting something rotten. Did they teach you hemolysis reduction in your nursing program, or did you just happen to remember an unusually detailed fact about for technique? The thing about being invisible was that it required constant work. Every word chosen. Every breath timed. Every response positioned to deflect rather than defend. Sarah had learned this in places where the wrong answer to a basic question could get you killed. This was just a hospital. The stakes were lower here. Theoretically. Standard curriculum, she said. Minimizing red cell destruction is part of every vascular access module. Standard curriculum. Pierce nodded slowly, his eyes moving across her face like he was cataloging things. Her height. Her posture. The calluses on her hands. The way she stood with her weight balanced in a way that made her immediately mobile. You know, I review about 40 nursing files a year coming into this ICU. Your qualifications were certainly adequate. But adequate nurses don't usually handle patients with the kind of confidence I just observed. Almost like you'd done something similar before. Silence. The fluorescent lights buzzed their mechanical hymn. Somewhere down the corridor, a monitor alarm sounded and immediately stopped, someone catching a problem early, responding without panic. The sound of good nursing. The sound of experience. I'm careful about my technique, Sarah said. I'm sure you are. His smile didn't change. Very careful. Careful enough that it looks like muscle memory instead of concentration. Careful enough that it looks practiced. He paused, letting the weight of that word settle. Practiced. As if careful and practiced were accusations instead of compliments. I wonder where you practiced before you came here. Previous facilities, she said. Yes, I read that. 6 months in Phoenix. 8 months in Denver. Very mobile for someone just starting in critical care. He took a step closer, and the pressure changed. This was the moment where dominance established itself, where hierarchy reminded the smaller creature of its place. I'm the attending physician on this unit, Ms. Chen. That means I'm responsible for every decision made here. Every procedure. Every intervention. Every nurse working under my supervision. The emphasis on the last 3 words landed precisely where he intended. I understand, Sarah said. Do you? He pulled the chart for Colonel Reeves, scanned the vitals, and made a small noise of satisfaction. You placed that 4 at the exact angle that would minimize valve damage and hemolysis. You changed the dressing on a patient whose protocol says dressing changes happen every 72 hours, and we're at 34. You knew that the chest tube in bed 6 was kinked before anyone reported pressure changes. You read this unit like you've been running ICUs instead of supporting ICEs. He handed the chart back to her. Here's what's going to happen. You're going to stick to the protocols exactly as written. No more creative for angles. No more early dressing changes. No more anticipatory nursing. You take your orders from me or the residents, and you implement them exactly as given. You don't improvise. You don't use that expensive education to override the attending physicians. You follow the chain of command. He smiled again. Teeth showing. We clear. Crystal clear, Doctor, Sarah said. She meant it. She'd operated under worse rules than this. She'd operated under rules where the only option was death or compliance, and she'd chosen compliance 7,000 times and lived with the consequences. One attending physician trying to establish dominance was significantly less complicated than an extraction team with standing orders to neutralize rather than retrieve. Good, Pierce said. I'm glad we understand each other. He walked away toward morning rounds, Jacobson scrambling to catch up, and Sarah stood motionless for exactly 3 seconds. Then she moved back toward the med cart to restock supplies. The efficiency was automatic. Hands knew what to do. The mind could stay somewhere else entirely. But that night, in the break room at 1:15 a.m., while she was eating the sandwich she'd brought from home, she heard Pierce's voice coming from the doctor's lounge next door. The door was cracked. Voices carried. She could have moved away. Should have moved away. Instead, she sat perfectly still while he talked to 3 other attending physicians about the new nurse on night shift who seemed to have some kind of background that made her think she was more qualified than she actually was. Probably military nursing, he was saying. They get that false confidence from field hospital experience. Think they're surgeons because they've sewn someone back together in a blackout. But civilian medicine requires different skill sets. Different respect for hierarchy. One of the other doctors laughed. She's competent enough, another said. I'd let her manage my for any day. That's exactly the problem, Pierce said, and his voice dropped lower so she had to strain to hear it. Competence without oversight breeds arrogance. And arrogance in nurses gets people killed. He paused. I'm documenting everything she does. One mistake, one protocol deviation, and I'm going to the CMO with a recommendation for immediate termination. We don't need cowboys on this unit. Sarah set her sandwich down on the plastic container. Picked it back up. Took a bite she didn't taste. This was the moment where the game changed. This was the moment where she made a choice, disappear or fight. Invisible or visible. The problem was that the only way to win was to stop being invisible, and the only way to survive had always been to stay hidden. She finished her sandwich at 1:17 a.m. and went back to work, moving through the ICU with the same methodical precision, the same careful deferential posture, the same flat professional voice answering every question that came her way. But she was waiting. She sat alone in the break room at 2:43 a.m., cold chicken and rice on a chipped ceramic plate, fluorescent lights buzzing overhead like angry insects. The sandwich her sister had packed 3 days ago had turned the letters brown. She ate it anyway. Around her, the break room was empty except for the hum of the vending machine and the distant beep of monitors through the walls, the constant percussion of St. Michael's ICU, that mechanical heartbeat that never slowed. Sarah had learned long ago that hunger was just information, like pain. You noted it. You moved forward. The door opened at 2:44 a.m. 3 nurses entered, Martinez, Chen, and Holloway from the evening shift, which meant they were finishing charting before going home. They saw Sarah. The room temperature dropped approximately 4 degrees. Martinez gathered her half-eaten yogurt and a granola bar. Chen collected her phone. Holloway waited exactly 2 seconds, then followed them out without making eye contact. The door swung shut. The vending machine hummed. Sarah chewed and swallowed and didn't look up. This was the 5th time this week. The pattern had started on Tuesday after Dr. Pierce had pulled her aside in the hallway and mentioned, very casually, that she'd contaminated a sterile field during the Vasquez line insertion. She hadn't. He'd been in the supply closet. But the other nurses had heard him say it, and nurses talked to nurses, and by Wednesday morning the break room had developed the kind of silence that comes from coordinated cruelty. It wasn't dramatic. It was worse than dramatic. It was systematic. It was institutional. It was the kind of thing that wore a person down grain by grain, like wind over sandstone. Sarah finished her lunch at 2:51 a.m. and went back to work. The morning arrived grey and heavy, clouds pressing down over Colorado Springs like a fist. Sarah had been working for 16 straight hours, a double shift that Dr. Pierce had scheduled personally and then casually mentioned to the chief nursing officer was a necessary given staffing shortages and Nurse Chen's recent competency concerns. By 6:56 a.m., she was running on coffee that tasted like rust and the kind of focus that came from knowing you were being watched constantly. She was documenting vital signs on Mr. Moreno, a 58-year-old construction supervisor with septic shock, when Dr. Pierce rounded. His voice carried across the ICU unit like a voice designed to carry, clear, confident, and loud enough for the Moreno family, who were clustered at the bedside with their overnight vigil exhaustion etched into their faces. "Nurse Chen," he said, stopping at the monitor station with 2 residents trailing behind him like pilot fish. "Perhaps you'd like to explain why you adjusted Mr. Moreno's vasopressor dosage without consulting me." Sarah looked up from the computer. Her vital signs hadn't changed, heart rate steady, shoulders level, breathing normal. His MAP was dropping below 60. Standing orders allow for titration based on perfusion parameters. Standing orders, Pierce said, and he was smiling now, that particular smile that made the residents straighten their spines, are for competent nurses who understand their limitations. Not combat medics playing doctor. The room didn't go quiet because it was already quiet. But it became a different kind of quiet. The kind where even the machine seemed to be listening. Mr. Moreno's daughter, a woman in her 30s with her father's construction worker hands, made a small sound, not quite a gasp, but not a gasp either. She looked at Sarah the way you look at someone who's just been publicly accused of something serious. Sarah set down her pen. Her hands were perfectly steady. She turned in her chair and met Pierce's gaze directly, and when she spoke, her voice had dropped so low that Pierce had to lean in slightly to hear it, which meant the residents had to lean in, which meant everyone was suddenly drawn in, which meant the power dynamic in the room had shifted in ways Pierce wouldn't understand until later, if he ever understood it at all. "I understand my limitations perfectly, doctor," she said. "I've never let a patient die because I was too proud to act fast." 5 seconds of silence followed. Not the dramatic silence of television. The real silence, thick, heavy, populated by the sound of the ventilator wheeze and the monitor's steady rhythm and the collective intake of breath from people who'd just witnessed something. Pierce's jawline tightened. One of the residents looked at his shoes. Sarah turned back to her chart and resumed typing. Pierce recovered after approximately 3 seconds, his voice clicking back to its rehearsed authority. "We'll discuss this in my office," he said. "After your shift." But he was already walking, already moving to the next patient, already trying to rebuild the version of himself that Sarah had just dismantled with 6 sentences and a stare. The residents followed. Mr. Moreno's daughter continued staring at Sarah, and something in her expression had changed, not gratitude exactly, but recognition. The kind of recognition that comes from watching someone refuse to break. Sarah finished her shift at 7:15 a.m. She didn't go to Pierce's office. By Friday, something had shifted in the ICU's social architecture. The whispers had evolved. Now it wasn't just that Sarah had contaminated a field or falsified credentials. Now she was insubordinate, disrespectful to attending physicians, a safety risk. The other nurses moved around these words like they were furniture. They stopped gathering their lunches when she entered the break room. Instead, they left one by one, a coordinated departure that was somehow more cutting than direct confrontation because it required no confrontation at all. Just abandonment in increments. By Tuesday of the following week, Sarah had begun eating her lunch in the supply closet. By Wednesday, she was eating in her car. By Thursday, she'd stopped eating lunch altogether. It was Thursday morning, 6:34 a.m., when Sarah arrived to find the write-up posted on the unit board in the main hallway. The announcement board where schedules were posted and continuing education credits were listed and birthday cakes were celebrated, that board now bore Dr. Pierce's handwriting in thick black marker. RN Chen, exceeding scope of practice. Unauthorized clinical interventions. Counseling required, immediate. The marker had bled slightly into the board's laminate surface. The letters were thick, aggressive, written by someone who'd pressed hard. It was the kind of thing you couldn't miss if you walked past the board, which everyone did, which was obviously the point. A family waiting nearby for visiting hours stared at the announcement, then at Sarah, trying to draw connections. A nurse from pediatrics whispered something to a resident. Sarah read each word with the kind of attention she usually reserved for wound assessments. Her breathing remained level. Her hands remained still. But something in her chest had shifted, not fear, not anger, but a kind of compression, like pressure building in a sealed chamber. She reached out and touched the edge of the board. The laminate was cool. She could smell the marker solvent base, that sharp chemical bite that somehow made everything feel more official, more damaging, more real. Then she turned and walked toward the ICU, where a 14-year-old boy with pneumonia needed his oxygen saturation checked, and a 62-year-old woman with congestive heart failure needed medication reconciliation, and a 31-year-old man recovering from abdominal surgery needed his dressing changed. The work continued. The machines beeped. The monitors displayed their constant data streams. And Sarah moved through it all with the precision of someone who'd learned long ago that survival meant showing up, doing the job, and never letting anyone see the cost of it. But that wasn't the worst part. At 1:45 a.m., the ICU doors burst open and paramedics wheeled in a stretcher carrying a man whose skin had already begun turning blue, who wasn't breathing properly, whose body had already started shutting down. The radio crackled, tension pneumothorax, left side, O2 sat dropping fast, ETA to your door is now, trauma surgeons 15 minutes out, patient is Colonel Marcus Reeves, military transfer, priority patient. The on-call resident froze. The resident was young, maybe 2 years out of medical school, and his mind was doing that thing minds do when faced with immediate catastrophe. It was calculating probabilities and recalling textbook procedures and finding nothing useful because textbooks don't prepare you for the moment when a man's lung has collapsed and he's running out of oxygen and the surgeon is still 15 minutes away. Sarah was already moving. She didn't think about it. Her hands reached for the needle decompression kit while her body moved toward the patient. The 14-gauge catheter was in her grip before her conscious mind caught up to what her muscle memory was doing. She positioned it at the second intercostal space, mid-clavicular line, the precise anatomical point where the needle needed to go to release the pressure that was collapsing the colonel's lung. The angle was perfect. It came from 8 years of practice, from a rooftop in Baghdad with mortar rounds walking across buildings like footsteps, from a moment when a Marine had gone down and there'd been no surgeon and no sterile field and only her hands and her knowledge and the choice between trying and letting him die. The angle had saved his life that night. The angle saved this one now. She inserted the needle with absolute confidence, and the release of pressure was audible, the distinctive hiss of air escaping, and Colonel Reeves gasped, color flooding back into his face like someone had reversed the video. His eyes flickered open mid-procedure, and they locked on her hands. Specifically on her hands. Specifically on the angle of the needle, the way she stabilized the catheter, the surgical precision of her movements. His voice came through the oxygen mask as a rasping whisper, "That's a Bragg Medic's needle angle. Who taught you that?" The room had been chaos. Now it became something else. Sarah's face went completely still. The other nurses froze. The resident's calculation stopped. And in that moment, 3 seconds, for at most, Sarah and Colonel Reeves locked eyes, and something passed between them that existed in a register below language. Recognition. Not of her face, not of her name, but of the specific way a person held a needle when they'd done it 1,000 times. When they'd done it under fire. When they'd done it because lives depended on it. Securing the catheter now, she said softly. Her voice had changed. It was quieter but somehow larger, like someone had turned down the volume and turned up the authority at the same time. She finished the procedure with the same precision. The attending physician arrived, not Pierce, thank God, but Dr. Holloway from trauma, and began running the full assessment. Sarah stepped back, and her hands, which had been absolutely steady 3 seconds ago, had begun to tremble very slightly as she pulled off her gloves. Not from fear. From restraint. She walked to the supply room, closed the door, and leaned against the cool metal shelving unit. Her breathing was controlled but deeper than normal. She reached into her jacket pocket and her fingers found the faded unit patch sewn into the lining, a Delta Force insignia, worn at the edges, fraying at the corners, stitched there by hand she hadn't thought about in 4 years. She pulled it out. Held it. And in the fluorescent light of the supply room, surrounded by sterile gauze and 4 bags and all the equipment that kept people alive, she closed her eyes and understood that some things don't stay buried because they were never meant to be graves. They were seeds. And seeds, when they finally find soil, don't grow quietly. The ambulance doors burst open at 01 for 5 hours, paramedics moving with the controlled urgency of men who'd learned the difference between fast and panicked. Colonel Marcus Reeves lay on the stretcher, his chest heaving in shallow, gasping pools, his skin the color of wet concrete. Sarah was already moving before the trauma alert hit the intercom, her body recognizing the sound signature of a man drowning in his own blood. Delta Force training accident at Fort Carson, the paramedic called out, stripping the vital sheet like a checklist. Fall from a 40-foot rappel line. Blunt force trauma to the right chest. O2 sat dropping, breath sounds absent on the right. We decompressed in the field but something's still wrong. Sarah's hands reached for the stethoscope hanging around her neck before her conscious mind caught up. She listened across his right lung field. Nothing. Dead air. The left side whistled with compensation, working double time, burning itself out. She pulled back the oxygen mask paramedics had taped to his face and looked directly into his eyes, pupils equal and reactive, but foggy with the specific kind of pain that came from serious internal injury. Get him to Bay 3, she said, and the residents scattered like birds. Bring the portable ultrasound. I need a 14-gauge angiocath needle, chest tube setup, and someone call CT. Actually, no. No CT. He's crashing too fast. She was already moving, already thinking in the compressed shorthand of someone who'd done triage in buildings still smoking from airstrikes. Her hands gripped the stretcher rail as they wheeled him into the ICU, her fingers steady as surgical steel. The bay doors slid open and fluorescent light flooded across his face. Sarah had seen this before, not in Colorado Springs hospitals with their gleaming equipment and 5-person teams standing by, but in field surgical hospitals in Baghdad, under generator power that cut out every 3rd minute, with dust falling from the ceiling and mortar rounds walking closer. The presentation was identical. The treatment was identical. The difference was that here, she had resources. Here, she might actually save him. Dr. Pierce was nowhere to be found. Good. Sarah was moving on pure muscle memory now, the kind that lived deeper than conscious thought. She positioned Reeves supine, ran her fingers across his rib cage to find the anatomical landmarks, the second intercostal space, the midclavicular line, and prepped the skin with chlorhexidine that smelled like antiseptic and purpose. The needle was already in her hand, her arm moving with the precision of someone who'd done this 17 times under circumstances that would have made most surgeons weep. Talk to me, she said to the residents who'd assembled like lost children. What are we looking at? One of them, a 3rd year named Patterson, swallowed hard. Tension pneumothorax. The air's compressing the mediastinum, collapsing venous return. If you don't relieve the pressure in the next, he looked at the monitor, where blood oxygen was bleeding downward like a stock market crash. 3 minutes, his heart stops. Sarah was already inserting the needle, her angle specific and practiced, the kind of angle you learned from a medic who'd trained in the 75th Ranger Regiment and passed it along to you while you both sat in a converted shipping container in Fallujah, waiting for the next extraction call. The needle slid past the pleura and there was a hiss, the sound of pressurized air escaping, the sound of a man's lungs suddenly remembering how to breathe. The colonel's body convulsed, a gasp pulled from somewhere deep, and his eyes snapped open. They found Sarah's immediately, locked on with the kind of clarity that comes when you're suddenly no longer suffocating, and his mouth moved, words forming through the pain that was still screaming through his body. "That's..." He coughed, the sound wet and controlled. "That's a Bragg medic's needle angle. The way you, or the depth at the approach." His eyes didn't blink. They searched her face like he was reading a map to somewhere he'd been before. "Who taught you that?" The room went so quiet the fluorescent light sounded loud. 3 residents stared. A nurse in the corner froze with a unit of blood in her hands. Sarah's expression didn't change, no widening of the eyes, no flush in her cheeks, no tremor in the hand that was still holding steady on the needle. She simply met his gaze and held it for exactly 1 second, then moved on to the next task with the composure of someone who'd held fire under circumstances that would have broken most people into pieces. "Pressure's improving," she said, her voice level and surgical. "Get me a 36 French chest tube. And run another liter normal saline wide open. This bleeding isn't over." She packed gauze around the needle decompression site with movements that were economical and certain, every gesture drawn from a library of procedures performed in field hospitals where mistakes meant funerals. The colonel's oxygen saturation was climbing now, 78, 82, 87, numbers marching upward like soldiers returning from a battle they'd almost lost. His blood pressure stabilized at 98/60, not great, but breathing. Survivable. The kind of vital signs that meant he'd make it to the operating room if nothing else decided to catastrophically fail in the next 20 minutes. The chest tube went in with a wet slide of resistance that felt almost like relief. Sarah's hands moved with the terrifying fluid precision of someone who'd learned anatomy not from textbooks but from experience, from the specific kind of education that only came from having to save lives when every second mattered and hesitation meant death. She connected the tube to a drainage system and watched as dark blood began pooling in the collection chamber, frank hemorrhage, which meant they'd found the bleeding source, which meant the sheared intercostal artery that had been leaking into his pleural space was now accessible. "Fluid's coming out fast," Patterson said, his voice climbing toward panic. "That's active bleeding. He's gonna need surgery immediately." The colonel was conscious now, his eyes tracking every movement in the room, his breathing still labored but no longer desperate. He watched Sarah work and something passed across his face, recognition, or memory, or the specific kind of understanding that comes when you see someone do something they've done 1,000 times before under impossible circumstances. "How long?" He started, then coughed. "How long were you in?" Sarah was moving to the wall phone, dialing the surgical floor. "Cardiothoracic to ICU. We need a room prepared. Sheared intercostal artery, active hemorrhage, soldiers stable enough to move." She didn't answer his question. She didn't look back at him. She simply continued working with a kind of focused intensity that made everyone else in the room seem like they were moving in slow motion. The night stretched ahead like a tightrope, Sarah working through the hours with an efficiency that was almost mechanical. Blood work, labs, repeat chest x-rays that showed the lung re-expanding as fluid drained from the pleural space. The colonel stabilized by 200 hours, his oxygen improving, his blood pressure holding steady, his bleeding rate slowing to a gentle trickle that suggested the initial catastrophic hemorrhage had been controlled by gravity and the collapsed lung doing its job of tamponade. But then his monitors screamed. The monitors screamed at 300 hours like something alive was dying inside the machine. Colonel Marcus Reeves's chest cavity was filling with blood. Not the slow trickle from before. This was hemorrhage, catastrophic, accelerating, the kind that kills in minutes. His oxygen saturation plummeted, 92, 88, 74. His blood pressure dropped like someone had pulled a plug, 120/80, then 90/50, then 70/40. The ventilator wheezed its mechanical rhythm, fighting a battle it was losing. Sarah was at bedside in 4 seconds. Not running. Walking fast the way trained medics walk, economical, purposeful, no wasted motion. The intern at the monitor looked up, voice panicked. His chest tube output just jumped to 400 milliliters in the last 5 minutes, the bleeding's accelerated, his hemoglobin's dropping, we're losing him. Sarah's hands were already moving, palpating his chest wall, feeling the absence of breath sounds on the left side where the initial pneumothorax had been. The pressure was back. But this time it wasn't air causing the collapse. It was blood. A sheared intercostal artery, probably from the trauma that caused the original injury, bleeding into the pleural space now that the initial tamponade had shifted. She pressed the call button for the cardiothoracic surgeon. Then again. Then a third time, her voice level and precise, stat cardiothoracic to ICU. Colonel Reeves, bed 4. Hemorrhagic shock. The overhead paged the surgeon's name twice. Sarah was already moving to the code cart, her mind running through the geometry of what needed to happen. A 14-gauge angiocath needle wouldn't stop this. Chest tube drainage wouldn't stop this. Only one thing would stop this. An emergency thoracotomy. Open the chest wall, get her hands on the bleeding artery, clamp it, close it, get him back to the OR. Everything else was just buying time. Dr. Pierce appeared in the doorway like he'd been summoned by her thoughts. Not the cardiothoracic surgeon. Pierce. His face had that look it always had when he smelled blood in the water, anticipatory, hungry, the expression of a man who'd learned early that chaos was opportunity if you were ruthless enough to exploit it. He walked to the monitor, looked at the numbers, looked at the colonel's color, and said, "He's gone. Stop compressions. Call it." Sarah didn't turn around. Her hands were already in the sterile field, drawing up medications, setting up the thoracotomy kit with the kind of speed that came from muscle memory buried deep in muscle fibers that had done this work on rooftops in Baghdad while mortars fell and the sky turned orange. "No," she said. Not a question. Not a request. A statement delivered in a voice that had changed without anyone noticing. Quieter now. Colder. The voice of someone who'd stopped asking permission about 6 years ago. Pierce's jaw tightened. "Nurse Chen, the patient is in profound shock with no response to initial interventions. Continuing resuscitation is futile and cruel." She was already scrubbing in. 30 seconds. Her hands moved through the ritual, soap, brush, nails, between fingers, up to the elbows, with a kind of mechanical certainty that made the intern step back. She'd done this before. Not in a hospital. On a stretcher in the back of a Black Hawk with rounds cutting through the fuselage and a combat photographer with a femoral bleed who was going to die if Sarah didn't get the bleeding stopped in the next 60 seconds. The photographer had lived. Sarah's hands remembered. "I'm calling the CMO," Pierce said, voice rising now, that performative concern dripping like honey over broken glass. "This is insubordination. This is exceeding scope. This is criminal negligence." He was already moving toward the phone at the nurse's station, already reaching for the receiver, his other hand raised in that gesture he used when he was about to summon authority like a dog summoning dinner. She could hear his voice through the glass wall. "This is Dr. Pierce. I need the chief medical officer. Now. We have a nursing emergency in the ICU." Sarah was already through the sterile field. Gloves on. Gown snapped at the back. The thoracotomy kit was open in front of her, surgical instruments arranged like a symphony waiting for a conductor. The scalpel felt right in her hand. It always did. She made the incision below the 5th rib, the blade moving through skin and muscle with the kind of precision that looked easy because the person doing it had done it hundreds of times. The retractor went in. She spread the ribs, felt them resist, then give, her fingers finding the space between the ribs the way a musician finds the right key by touch alone. The bleeding artery was right there. Pulsing. Arterial bleed from a sheared intercostal branch, soaking the pleural space, the color of rust water in the surgical light. She found it with her gloved fingers, her hands moving faster than conscious thought. A satin sky clamp from the kit. The artery clamped. The bleeding stopped like someone had turned off a faucet. The colonel's pressure stabilized. 90/60. 100/60. 110/65. His oxygen saturation climbed as the blood drained from his chest cavity, the thoracostomy tube drawing out what had pooled, and his lungs re-expanded. The monitors shifted from the screaming frequency of near-death to something almost normal. His rhythm was sinus. His oxygen was climbing, 74, 82, 90. Stable. The ICU door burst open. Security. 2 uniformed guards and a supervisor in a security vest. The chief medical officer behind them in pajamas and an overcoat, his face the color of old concrete, exhausted in the way that came from being pulled from sleep at 0300 with news that something catastrophic had happened on his watch. And Dr. Pierce. He was moving fast, already talking, his voice reaching that pitch it got when he was painting a narrative he'd spent considerable time constructing. I attempted to stop her, Pierce was saying to the CMO, his voice laden with regret like a pallbearer carrying flowers. She refused direct orders. She contaminated the sterile field, exceeded every limitation of her licensure, performed a surgery that only an attending physician can authorize. She's quite possibly ended this man's life with her recklessness. Sarah finished closing the chest wall. 2 hands. Practiced efficiency. The kind of efficiency that made everything else look clumsy. She peeled off her gloves without looking at any of them. His pressure's stable, she said to no one in particular. Arterial bleed from a sheared intercostal. I clamped it. He needs the OR. 30 minutes maximum before the clamp starts damaging tissue. The CMO's eyes moved from the colonel to the monitors to Sarah to Pierce. The calculus of institutional power, playing out across his face in real time. A surgeon who'd worked here for 7 years versus a nurse who'd appeared out of nowhere 6 months ago. A doctor with a reputation versus a nurse with no background check yet filed because of the accident this morning. An attending physician whose brother-in-law was on the hospital board versus night shift staff. Nurse Chen, the CMO said, and his voice had that careful quality it got when he was protecting himself. Your badge. Now. She didn't hesitate. Not because she accepted the decision. Because she'd known since the moment she scrubbed in that this was the endgame. You don't defy institutional hierarchy in front of witnesses and survive it. She unclipped her badge from her scrubs and handed it over. The plastic was still warm from her body. The photo showed a woman who looked hollow-eyed and exhausted, like someone who'd been running for 6 years and had finally stopped. The security guards moved on either side of her, not rough, not threatening, just present. Institutional enforcement. They walked her out of the ICU while Pierce was still talking to the family members who'd arrived in their wrinkled clothes and sleep-creased faces, his voice dripping with that artificial concern he'd perfected. Unqualified staff compromised your loved one's care, he was saying. I did everything possible to prevent it. Everything possible. The walk through the hospital corridors at 0400 hours felt like walking through a mausoleum. The night shift workers who saw her pass, the respiratory therapists, the laboratory techs, the cleaning staff, they stared the way people stare at someone who's been erased. By 0410 she was at the security desk on the main floor, watching the guard scan her badge one last time. The system beeped. Access denied. The badge was deactivated. She was no longer anyone. The parking lot was empty except for her car. She sat in the driver's seat for 20 minutes without starting the engine, her hand still shaking with adrenaline that had no place to go. The unit patch was in her jacket pocket, the faded fabric with its insignia of a skull and crossbones, sewn into the lining by a medic named Holloway in Fallujah, a man she'd saved by tourniquet when he'd stepped on an IED and lost everything below the knee. She'd kept him talking until the medevac arrived. He'd sent her this patch 2 years later with a note that just said, "Never forget who you are." But she had. For 6 years, she'd forgotten. She'd buried Captain Sarah Chen so deep that night shift nurse Chen had felt real. Had felt like a person who could build a life. Could show up to a job and do good work without anyone asking questions about where she'd learned to do it. And now that identity was erased too, and she was sitting alone in a car at 0430 in the morning, holding a patch that proved she'd ever existed at all. She drove to the all-night diner on Academy Boulevard. The fluorescent lights were too bright inside, the kind of bright that made you wish you were back in the dark. She ordered coffee and sat in a booth by the window. The coffee grew cold while she stared at her reflection in the glass, hollow-eyed, exhausted, a woman who looked like she'd been running from something and had finally stopped. The patch was in her hand now, the fabric worn soft by repeated touching, the skull and crossbones nearly faded to ghost image. She'd spent 6 years trying to disappear. And she had. Just not in the way she'd intended. The hospital's routine background check flagged Sarah's security clearance the next morning, a Tier 5 classification that shouldn't exist for a civilian nurse. By noon, 2 Pentagon liaisons sat in the chief medical officer's office while Dr. Pierce, smugly confident, prepared his termination recommendation. He'd already deleted the security footage. No video meant no proof. No proof meant her word against his. He'd won before the meeting even started. The colonel, awake now and lucid in his recovery bed, whispered to his visiting unit commander about the nurse who'd saved his life. Call sign was Raptor 6, he'd said, his voice still rough from the endotracheal tube. The Marine brigadier went pale. He pulled out his phone. Within an hour, he was reading aloud in the packed conference room, his voice carrying the weight of official military record, Captain Sarah Chen, Bronze Star with Valor. The room held its breath. Purple Heart. Someone gasped. Credited with 17 critical saves under fire in Operation Phantom Fury. The silence was so thick you could operate in it. Dr. Pierce tried to interrupt, his voice rising about protocol and proper channels, about maintaining standards and the dangers of emotional decision-making. But the door opened. A 2-star general walked in. General Vasquez, Deputy Commander of U.S. Army Special Operations Command. She took one look at the medal citation displayed on the screen and came to attention in a rigid salute, the kind of salute that comes from the chest, from muscle memory of respect that runs deeper than rank. Every veteran in the room snapped straight. The officers stood. Even the CMO straightened, understanding suddenly that he was in the presence of something that outweighed his hospital hierarchy by orders of magnitude. Pierce's face had gone the color of old bone. He'd made a calculation error. A fatal one. The strategic competence that had served him so well, the whisper campaigns, the policy weaponization, the careful reputation destruction, meant nothing now. Those tools were designed for hospital politics. They were toys. They couldn't touch what walked through that door wearing stars on its shoulder. The general spoke once, quietly, Dr. Pierce, you're suspended pending investigation. You will not be discussing this case with anyone. You will not contact the patient or his family. You will not attend this hospital in any official capacity until the State Medical Board completes their review. It wasn't a request. It was a command delivered in a voice like a tank idling in a garage, all barely contained power, no wasted sound. What the general didn't know yet, but would learn within the hour, was that Pierce had accessed the security footage system at 04:45 that morning. He'd gone into the ICU camera logs and deleted files 0300 through 0400, the entire window of Sarah's thoracotomy. He'd stood in the dark server room with sweat on his palms and carefully erased the only video evidence that she'd performed a surgical procedure. Without footage, it was her word against his. An erratic former soldier against an established attending physician. He thought he could still win. He would have. It was elegant, really. Completely clean. Except for one problem. Marcus Webb stood from the back of the room. 42 years old, hospital IT administrator, a quiet man who'd never said much during staff meetings. But he was wearing an old Army combat patch on his civilian jacket, a tan and brown patch with a castle crest. He'd done 2 tours with 160th SAW Night Stalkers before a rotator cuff injury had ended his flying days. He understood chain of command. He understood that some things, once deleted, belonged to the official record. He'd flagged the server breach per hospital policy the moment Pierce's credentials had accessed the system. Webb's voice was steady when he spoke. Dr. Pierce accessed the security system at 04:45 this morning and deleted files 0300 through 0400, ICU camera 3. I preserved every frame before deletion and flagged the breach per hospital policy. He connected his laptop to the projector. The footage appeared on the screen. Sarah's hands moving with surgical precision. The arterial clamp positioned perfectly at the sheared intercostal artery. The Colonel's vitals stabilizing as she worked, blood pressure climbing, oxygen saturation rising, heart rhythm converting back to something that looked like life. 100 seconds of flawless field surgery performed in a hospital ICU at 3 in the morning. Then Webb pulled up a second screen. Time-stamped logs of Pierce's deletion attempt. His admin credentials. His IP address. His email forwarding the footage to himself 20 minutes later, the only file he'd managed to save before Webb locked him out. Evidence of a man trying to destroy evidence. A doctor attempting to bury proof that a nurse had saved a patient's life. I've already forwarded this to the State Medical Board, Webb said, his voice carrying the kind of quiet authority that comes from having stood on helicopter ramps with rotors beating, along with documentation of Dr. Pierce's interference with patient care. Specifically his refusal to call the cardiothoracic surgeon when the patient was bleeding out. Webb looked at Pierce. That's not hospital politics, doctor. That's patient abandonment. The room erupted. Not in anger, in the kind of shocked silence that precedes collapse. The CMO was standing, phone already out. A lawyer materialized in the doorway. Someone was calling hospital security. Pierce tried to leave, but General Vasquez moved to the door, blocking his exit with the kind of subtle repositioning that made it clear he was not going anywhere. His hands were trembling. Not the kind of trembling that came from fear, but from the realization that every strategic move he'd made, every careful political maneuver, every calculated cruelty, all of it was now evidence against him. The investigation that followed was methodical and complete. Interviews with staff revealed the systematic destruction of Sarah's reputation. The rumors about falsified credentials. The reassignment that isolated her from allies. The public humiliation in front of the dying man's family. Every whispered conversation in the doctor's lounge. Every carefully placed insinuation. The pattern of a man using institutional power as a weapon and using it with precision. What Pierce hadn't counted on was that precision being documented. That precision being preserved. That precision being presented to a two-star general who understood that leadership meant protecting those under your command, and that Sarah had been under the command of Special Operations for 8 years, serving with distinction that Pierce couldn't comprehend with his small, administrative mind. The State Medical Board's findings came back in 6 months. Dr. Pierce's attending privileges were revoked. His medical license was suspended pending a 6-month probation requiring remedial ethics training. The hospital settled quietly with Sarah, a restoration of her full record, back pay, a promotion to trauma coordinator, and a private written apology from the CMO. But the real consequence came from Pierce's own profession. His peers stopped returning his calls. No hospital in Colorado would hire him. His reputation, so carefully constructed over 20 years, evaporated in the span of an afternoon. Sarah Chen stood in the St. Michael's ICU wearing her badge again. Not as a nurse. As a trauma coordinator. The badge carried her name and her title, and underneath, in small letters that only she could see when she looked down, was a note handwritten by the CMO, with apologies and respect. Through the ICU window, she watched Dr. Pierce in the loading dock area. Stripped of his attending privileges, his white coat gone, he loaded supplies into a medical transport van, the only position the hospital would allow him while under investigation. The van belonged to a temporary staffing agency. He'd be gone in another month, moved on to some smaller facility, some clinic in a smaller city where his reputation hadn't preceded him. But for now, he loaded supplies with the posture of a man who understood that power, once lost, doesn't return gently. Sarah didn't feel triumph. She felt something closer to quiet settling, the kind of peace that comes from knowing that some debts get paid not through revenge, but but through consequence. He'd tried to bury her. Instead, he'd buried himself. Behind her, a voice cut through the ICU's mechanical breathing, "Captain Chen." She turned. Colonel Marcus Reeves stood in full dress uniform, recovered, the thin scar barely visible at his chest where they'd cut him open at 3 in the morning. He was lean still, moving with the careful precision of someone whose body was still learning to trust itself, but his eyes were clear. Alive. The kind of alive that doesn't happen without someone understanding the difference between conventional medicine and battlefield survival. "It's an honor to still be breathing," he said. Sarah nodded. She reached into her jacket pocket and touched the faded unit patch, the one she'd sewn back into the lining after her termination. The patch with the Delta Force emblem, worn soft by 2 decades of carry, given to her by a medic she'd saved in Fallujah. She'd carried it as a splinter she couldn't extract, a piece of identity she couldn't shed. Now it felt different. Not like a splinter. Like something else. Something that had always belonged there. The colonel continued, his voice steady, "They're asking if you'd consider returning to active duty. Advisory role, training combat medics at Fort Bragg. Special Operations Command thinks you could reshape doctrine." He paused. "Your choice, Captain. The doors open either way." Sarah looked out at the ICU. Nurses at their stations. Patients fighting to survive. The work that mattered. The work that didn't require a rank or a patch or a Pentagon liaison to validate. The work that saved lives in the ordinary dark, without cameras, without recognition, without medals. "I'm exactly where I'm supposed to be, Colonel," she said. He smiled, came to attention, and saluted. The kind of salute that carries respect not because of rank, but because of recognition. She returned it, and he left the ICU with the same fluid precision he'd arrived with. Sarah returned to her rounds. By afternoon, the break room felt different. Nurses made space for her at the table. Asked her opinion on a difficult case. Listened when she spoke. The ostracism had evaporated with Pierce's reputation, but that wasn't what mattered. What mattered was that they understood now. Not just that she'd been military. But why military people did what they did. Why some people, when faced with a choice between protocol and survival, chose survival. Why some people didn't tremble when everything demanded that they shake. Late that day, a young nurse, new, nervous, still learning the weight of her own competence, approached Sarah's station. "Nurse Chen, I'm not sure I'm qualified to assist with the chest tube placement on room for 12. I haven't done one in over a year, and I don't want to." Sarah met her eyes with that same steady gaze that had once been armor against Pierce's cruelty, but now there was something else underneath the ice. Warmth. Recognition of a person standing where Sarah had stood once, doubting their own capability because someone had convinced them to. "Qualifications," Sarah said quietly, "are what you earn in the moment, not what's printed on a badge." She stood. "Let me show you." They walked to the patient's room together. The young nurse's hands were shaking slightly as they prepped the sterile field. Sarah moved beside her, not taking over, but showing. Demonstrating. Teaching. The needle going in at the precise angle. The catheter threading smooth. The sudden rush of air as the fluid drained and the patient's oxygen saturation climbed from 87 to 94 in 8 seconds. The monitor showing lungs expanding, heart settling, a body remembering how to breathe. As they cleaned up afterward, Sarah thought about power. Real power. Not the kind that came from titles or institutional position or the ability to destroy someone's reputation. Not the kind that lived in whisper campaigns and policy weaponization. Real power was what she'd just witnessed in a young nurse's hands, the ability to help. The ability to take knowledge and transfer it. The ability to stand in the dark and reach for someone who was drowning and pull them back to light. "Power is not a title," Sarah said to the young nurse, as they walked back through the ICU. "Power is the ability to help." And for the first time since Mosul, since the black site extraction that had gone sideways, since the Pentagon had erased her service and given her a new life and told her to disappear into the civilian world, for the first time, she believed it. If you've made it this far, you already know, the people who save your life might not be wearing the uniform you expect. Subscribe for more stories about the quiet warriors walking among us. And tell us, what would you have done in Sarah's position?